FC is a 47-year-old Caucasian female who was admitted last night. She's medically complex, and most of her problems stem from her diagnosis of colorectal cancer 6 months ago. Complications prompting this admission include inflammation around her chemotherapy port, which is associated with onset of fever, chills, shakes, and altered mental status. There's also a complaint of persistent lower calf pain. Past medical history is significant for CKD, hypertension, and prediabetes, and her chronic meds include lisinopril and metformin. Diagnostic workup yields bacteremia, DVT, and complications of CKD. While my full assessment appears on the chart, briefly note the following. FC suffers from uncontrolled bacteremia and sepsis secondary to a catheter-related infection of her subclavian port. This is evidenced by hypotension and elevated temperature, heart rate, blood pressure, and white count, with a preliminary isolation of gram-negative non-fermenting rods from 2 of 2 peripheral blood cultures. While alternate sources of infection have been ruled out, per IDSA guidelines for catheter-related bacteremia is complicated. Factors contributing to the infection include primarily duration of catheterization, but also malignancy and diabetes, with likely pathogens of concern including Pseudomonas as well as potentially Proteus and others. Our goals are to identify the pathogen, optimize antibiotics, cure the infection, and interrupt sequelae of septic shock. So regarding current treatment, first, she's receiving vancomycin, which I recommend discontinuing considering the preliminary pathogens. Second, she's also on meropenem, which is appropriate but not as monotherapy, as IDSA guidelines recommend dual gram-negative coverage in patients who are both septic as well as when drug-resistant pathogens like Pseudomonas are suspected. Thus, I recommend continuing meropenem 1 gram, but change to Q12 hours for renal dosing and give as an extended 3-hour infusion for 7 to 14 days after cultures are clear. Third, I recommend giving a single gentamicin 7 milligram per kilogram IV dose with a random gent level 10 hours later. I'm concerned about using aminoglycoside in a patient with CKD, but a single dose should provide coverage enough until culture and sensitivity results are available. And finally, I recommend removing the catheter and not attempting lock therapy. Monitoring should include follow-up of the pending CNS results so we can de-escalate antibiotics where appropriate, getting 2 sets of repeat cultures at 72 hours, signs of clinical improvement, and of course, renal function, CBC, and also monitor for diarrhea that may suggest C. difficile. Next, FC has a DVT that is uncontrolled, as evidenced by bilateral lower extremity ultrasound showing a clot in the right tibia vein. Based on a Corona score of 3, FC is at high risk for VTE, although studies show that there's no evidence of PE or suppurative thrombophlebitis. Although her DVT is distal, anticoagulation is favored, considering risks that include a markedly elevated D-dimer, malignancy, inpatient status, and obesity. The goal is to prevent recurrent VTE or post-thrombotic syndrome, despite bleeding risks that exist, which also include her metastatic cancer, CKD, diabetes, and anemia. As far as current therapy, FC is ordered heparin 5,000 units sub-Q BID. However, this is a prophylactic dose and inappropriate. NCCN guidelines indicate that given FC's metastatic cancer, that low molecular weight heparin is the anticoagulant of choice for both treating as well as preventing VTE, for which FC is also at risk. This is based on data that shows that low molecular weight heparin has greater risk reduction than the oral anticoagulants. So therefore, I recommend discontinuing the heparin, starting dalteparin 200 units per kilogram per 30 days, and then follow that by 150 units per kilogram for at least 3 months. Extended therapy to prevent VTE is likely required beyond 3 months, but a decision can be made later whether to change to a more convenient oral therapy. Monitoring for this should include watching for signs of bleeding, which are detailed in my plan on the chart, a platelet count to monitor for heparin-induced thrombocytopenia, and serum creatinine monitored every 3 days. Finally, based on her estimated GFR of 42, FC has high-risk stage 3 CKD with contributing factors that include prior acute kidney injury, hypertension, use of chemotherapy, and diabetes. As a result, FC has developed a number of CKD-related derangements. First, she has untreated moderate anemia that is uncontrolled based on a hemoglobin of 9.2, and she also has decreased ferritin, transferrin saturation, and red blood cell indices that are suggestive of iron deficiency. Regarding treatment options, transfusion and erythropoietin-stimulating agents are not appropriate at this time. I've detailed the reasons on the chart. But further, since KDIGO guidelines recommend avoiding iron during an infection, and since FC exhibits no overt symptoms of anemia or bleeding, I recommend that we delay the IV iron until the infection resolves. In the meantime, we can order an iron level, retic count, and total iron binding capacity to further elucidate the anemia. Oral options are certainly available, but IV therapy could more rapidly replace the iron stores. Second, she has an untreated severe hypercalcemia that is uncontrolled based on a corrected calcium of 14.8 that is trending high. To achieve the goal of a normal calcium level, I recommend multifaceted therapy. It includes aggressive rehydration with normal saline at 200 mils an hour to achieve 150 mils an hour urinary output. This is to enhance calcium excretion, but we must take caution to watch fluid status in this patient with CKD. Once intravascular volume is restored, we can use furosemide 10 to 20 milligrams IV PRN to force diuresis and further inhibit calcium resorption. I recommend, secondly, we give calcitonin 4 units per kilogram, which has a rapid onset to inhibit bone resorption and augment calcium excretion. Then get a repeat calcium level in 12 hours, and if a hypocalcemic response is seen, because of its short duration, repeat doses can be given, and I've outlined those doses. Also give zoledronic acid 4 milligrams, which would be effective in the long run within 2 to 4 days for maintaining hypercalcemia control. And monitoring should include serum calcium, potassium, and magnesium levels. Third, FC has untreated hyperphosphatemia that is uncontrolled based on a phosphate level of 5.8 that also is trending high, and a calculated calcium phosphate product that puts her at risk of calciphylaxis. To achieve a goal of a phosphate toward normal, I recommend initiating sevelamer 800 milligrams TID with meals. This is to inhibit GI absorption of phosphate, and eventually, once she's well enough to talk, to have a dietitian consultant for education on foods to avoid that are high in phosphate. Fourth, she has an untreated vitamin D deficiency that's uncontrolled based on a calcidiol level of 10. To correct vitamin D levels, which are modifiable risk for elevated parathyroid levels, I recommend initiating cholecalciferol 50,000 units once weekly for 8 weeks, followed by a maintenance dose that maintains a target calcidiol level. Serum levels of vitamin D, calcium, phosphate, magnesium, and parathyroid should be repeated after 3 months. And then finally, to assess fracture risk, I recommend performing hip bone mineral densitometry testing. I'll defer counseling of FC due to her critical illness, but all these treatment measures are consistent with her desire to keep fighting.